So go ahead and continue taking your food and come in and enjoy it while we start. So today's topic is cardiomyopathies, a very important topic. I would say every day in the echo lab, there are more than one or two cases that come through of some kind of cardiomyopathy. So by now, many of you are familiar with the topic and even with the imaging, but I think it's good to give an update and review it, and also hear some of the advancements that we're seeing with MRI. I would imagine next year we might expand this to maybe have more than echo and MRI, but maybe even PT, PET, and I guess CTA would be mostly in the ischemic side, but certainly imaging, it's expanding its role in the cardiomyopathy arena. So there are many ways to talk about, to define cardiomyopathy, classify them. This is just one of many. So this is using structural and functional abnormalities that affect the myocardium. On the structural, you have, of course, scars, fibrosis, inflammation, infiltration. Those are the most common things. Scar from a non-MI or from other diseases, fibrosis, we have been hearing a lot about that lately, inflammation and infiltration. From a functional point of view, you have ischemia. You may have stoning with dysfunction of the heart that gets better with revascularization. You may have cardiotoxic agents that may improve. You have pressure overload, you have volume overload, depending on lesions. And then you have genetic mutations that more and more are being discovered that either caused a cardiomyopathy or predisposes a patient to cardiomyopathy. For example, alcoholic cardiomyopathy is a well-known entity, right? People drink a lot, they get a cardiomyopathy. What % of drinkers get that? Very small percent. So there are likely genetic factors that then make that person be a lot more at risk when they do some heavy drinking. And then on this side, what we have is more specific diseases that would relate to what I just mentioned: myocardial infarction, myocarditis, vasculitis, sarcoid, hemochromatosis, amyloidosis. From the functional point of view, cardiotoxicity from chemotherapy, ischemia, hypertension, aortic stenosis, mitral regurg, AR. These are all now loading conditions that can end resulting in a heart failure syndrome or clinical entity. We are not going to discuss them because there are other opportunities to do that. And then a lot of genetic mutations every day, something new is being discovered. But in terms of diseases, we have the arrhythmogenic right ventricular dysplasia, the hypertrophic cardiomyopathies, non-compaction, and this entity that we call familial dilated cardiomyopathy. So echo helps a lot. It points in the right direction, although not always it gives us the diagnosis. So it's very easy by echo to see that you have a big heart, dilated, not functioning well. There are several echo Doppler findings that are going to point towards a restrictive type of phenomenon. Hypertrophy, of course, is relatively easy to see by echo. And then we kind of do a little guessing game. In truth is that most of the time by echo, we do a guessing game by putting the echo findings together with clinical findings. Assess severity of the functional abnormalities. Echo is very good at that. Volumes, LV mass, ejection fraction, left atrial size, hemodynamics. And many of these findings that we can do by echo will impact prognosis. So it helps us kind of classify patients into higher levels of risk. For instance, diastology, very well shown. If you have an EF of 35%, but your diastolic parameters, they all show normal left atrial pressures and PA pressures, you have a much better outcome than if you have a restrictive feeling with very high wedge. So clearly, there's a lot of findings that will help the clinician classify the patient in terms of risk stratify for risk. And that's why echocardiography has been kind of the main starting stem for these diseases. So if we think in terms of structural changes, we have dilated, hypertrophic, infiltrative. Let's kind of start with that. And frequently, this is what you see, right? A big heart that doesn't move well. So that opens the door for all kinds of possibilities. Ischemic, idiopathic, alcoholic, familial, even non-compaction at the beginning until you see more views. Postpartum, very common. Myocarditis, acute or chronic. Even sepsis can make a heart become depressed. Now, where you put this together with the picture, right? For example, a septic heart will be depressed, but likely will not be dilated because there won't be enough time to dilate. So you have a heart that may have a normal dimensions, but allows EF, and then you have a clinical picture of somebody who's septic. And then you treat that and they get better. Uremic could be a similar situation. So by tying the size of the heart together with the clinical scenario, often we can get close to knowing the etiology, but not because the echo itself has a specific finding for it. For example, this is a postpartum cardiomyopathy. Why is it a postpartum cardiomyopathy? Because I'm telling you, there's nothing in that image to know otherwise, right? It's a young woman in the peripartum stage, and the heart looks like that, and they are short of breath. So until proven otherwise, right? Until proven otherwise, it is a peripartum cardiomyopathy. Same thing here, right? 45-year-old guy, he's in heart failure, has a biatrial enlargement, has a big heart that functions poorly. But then you learn that he has positive HIV, and actually he has clinical AIDS. So that makes AIDS cardiomyopathy the most likely diagnosis. And he actually had been diagnosed for 5 years. He was receiving intensive medications. And we're seeing much less of this. Thank God. The HIV prevention that we have nowadays have really reduced the number of times that we see this type of situation. In fact, it's really now a very low incidence. It does have a very high mortality. Mechanisms are still being debated in terms of whether it's infectious versus autoimmune, nutritional deficiencies, and so on. I think treatments are probably not so well developed in part now because we're seeing a lot less of it. And this is a typical non-compaction. 40 technicians in the room. The best way to diagnose non-compaction is in the short axis views towards the apex, okay? Can we see a little bit of it here? Yes, but look how beautiful you see it here. Very nicely. So anytime you have a ventricle that doesn't look too good, not only do short axis in the standard mitral valve and papillary muscle, push it down towards the apex. You will see some beautiful diagnoses of that. So it's extensive spongy transformation of the myocardium, have been said similar to the fetal myocardium, coarse trabeculations and deep recesses, 2 layers of endocardium twice as thick as the epicardium. There's been some criteria that have been put together, but it's like your mother-in-law. You see one, you recognize it. All of this stuff is to write the papers. But in essence, that's what you have. You have these big intertrabecular recesses, okay? And they have put criteria in terms of this length versus the thickness here. But as you see one, you recognize them. So it's really, a lot of this stuff is just because people write papers, they have to have a definition so that they can go on. Hypertrophic cardiomyopathy, we know a lot about that. In fact, we have a whole hour of noon on that. So I'm only going to touch a little bit of it. The classic variant that we see most often, which is your asymmetric septal hypertrophy, systolic anterior motion, dynamic obstruction, again, very typical. And sometimes you don't see it at rest, but then you do a little bit of exercise, and bingo, you get it. So we know that. We know Valsalva. This was a Valsalva. But, you have the provocation, which you can do at the bedside with the murmur, and you can do in the echo lab, documenting the SAM and documenting the obstruction. Very importantly, by now, I hope all the fellows know this, There's absolutely no relation between the severity of obstruction and the severity of hypertrophy. Zero. It's a scatter plot. So you may have patients that have just a little bit of basal septal hypertrophy. In fact, this patient is not very impressive. That's a septum of about 1.4, because this is the RV trabecula. This is the septum right here. And the rest of the heart doesn't look that thick. So you have that little bit of basal septal hypertrophy and that amount of SAM with that amount of gradient. So the obstruction, the dynamic obstruction relates more to the anatomy of the mitral valve, posterior leaflet length, hyperdynamic contraction of the heart, and at times some curvature. Like here you see that the heart has a little bit of that shape. All of those findings relate more to the gradient than hypertrophy. You may have severe hypertrophy and no gradient whatsoever. And this is an important thing because we see a lot of these patients every day, and you know, echo looks like hypertrophic cardiomyopathy, and the majority do have it. However, we also see occasionally little ladies that have had a long history of hypertension, and now they're 82 years old, and they have a hyperdynamic heart, and they come in febrile with pneumonia, and lo and behold, they got a big-time gradient. Now, what are they? Are they a variant? Did they have some genes that took 85 years to penetrate? Or do they have just a very hyperdynamic heart, a sigmoid-like septum, which we see a lot in elderly? And when they become very hyperdynamic, if they have the right mitral valve apparatus changes, they may develop SAM. We even have seen acute MIs. Every year we see at least one acute MI, LAD, anterior MI, with a very hyperdynamic base, SAM, and big-time gradients. What are they? Are they acute MI in top of somebody that has some genes for ACM, and when they develop the hyperdynamic base, that happen, or are they something else? So the functional changes can be seen in clinical scenarios that are not really classic for HCM. That's the important message to remain. And in acute MI, it's super important to make that diagnosis because patient is hypotensive, pressures are being given, and you're killing them. The more pressure you give, the more hypotensive they get because they get more obstructed due to the SAM. So that's actually, in the acute MI setting, it's a crucial diagnosis to make promptly and be able to correct it. What's that? Carlos, what do you think that is? What does it look like? Not what do you think what is. What does it look like?
So the fact that there's hypertrophy, but EF is not that hyperdynamic points more to the amyloid.
Okay, so it looks like non-obstructive HCM, right? There's a lot of asymmetric hypertrophy. This septum is definitely a lot thicker than the base. EF is not that bad. It's not 70%, but it's, you know, it's in the 60s, and there's absolutely no SAM. Now, this could be HCM. Maybe we give a little stimulation with exercise of Valsalva, and bingo, we'll get the SAM. So maybe it is that. Okay, it's unlikely to be hypertension. It's certainly not aortic stenosis. It's not an athlete heart, that's for sure. Amyloid, maybe, but amyloid tends to be a lot more concentric than asymmetric, and this is not your sigmoid septum. And actually, this is one of the very few cases we have in our teaching file of Fabry's disease. So, again, the point I made earlier, echo shows structural changes, points to some direction, then we have to sort of finish the entire equation with clinical settings and sometimes genetic testing. So there is this rare list of diseases that, other than that, this one is usually fairly easy to pick up. And of course, these two are echo diagnoses that we should be able to make. But over here, we have these rare diseases that they can look like hypertrophic cardiomyopathy. And again, that's where your family history and everything else comes in so that you can be more suspicious and then do more definite testing beyond what we normally would do. One variant that is important to keep in mind, and we all see it, in fact, one of our case of the month in the journal was a patient with this variant, is the apical hypertrophy. Uncommon, but it happens. And again, it's one that we can miss. So here is your typical ACM, and here is your apical ACM. So a lot of hypertrophy at the apex, which can produce intraventricular gradients. The LV angio is classic with this spade looking like the ace spade in a card. But it's a diagnosis that not uncommonly we may miss by echo, because not all patients have beautiful echoes like this one. People come in with some level of difficulties in the image quality, and we may lose the appreciation for all the apical hypertrophy. However, number one, they often have EKGs with very, very deep, symmetric, bizarre T-wave inversions. That's always helpful. And if one uses contrast, then one should never miss it. So a couple of things is contrast. Sometimes color Doppler. This was one case where the color Doppler nicely showed it, because then it showed the beautiful intraventricular obstruction with the hypertrophy. Contrast is just as pretty as an MRI. So if you do contrast, you can save your MRI money and use it for something else. No, I'm serious. I mean, if contrast should always be 100% diagnostic for this. And as I mentioned to sonographers before, another situation where a short axis at the apex pays off. Again, notice at end systole, there's no cavity. It's all muscle. So for sonographers, you have to be suspicious. Short axis at the apex, very helpful, and pick up that contrast if you don't have a perfect image without it. And color Doppler can help you just by showing you findings that suggest that there is obstruction at the apical level. Otherwise, the MRI guys will come in and say, yeah, we made the diagnosis and you guys blew it. You didn't. All right. So infiltrative restrictive, again, as I said earlier, quite often we find in the echo findings suggestive of, but then you have to do more digging to get into a real diagnosis. And the ones that we see the most common here are the three first, amyloid, sarcoid, and hemochromatosis. Again, infiltrative tumors, it's a different type of situation, and those usually we can see. You see a little different texture in the echo and so on. Endomyocardial fibroblastosis, when you see one case, everybody comes and sees it because it is a rare disease. So here you have somebody that, again, looks like a concentric LVH, small cavity, EF in the 50s, could be many things. So the dogma that has been always preached is that the more increased wall thickness you have, accompanied by relative reduction in QRS voltage, that says amyloid, 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 until proven otherwise. Because you're having this tremendous thickness, which should give you a high voltage, and in contrast, you have a relative low voltage. It doesn't always have to be an absolute low voltage, but relative. So you may have a QRS of 6, 7 millimeters, which is not horribly low, but you have a ventricle like that. That should be suspicious. So, but there's nothing otherwise in the echo to give you a diagnosis. We talk about glistening of the myocardium here. I can show you some end-stage renals that look even better than this. So this is not necessarily a very helpful thing. EF can be variable. They do usually have biatal enlargement because of the functional abnormalities. Diastolic dysfunction is practically always there. And then you have this increased speckle appearance. Yes, if you have it, but you can hang your hat on that one. This is an example. Oops, this is an example. This particular patient already had at least type 2, if not type 3, abnormalities of diastole. Look at the tissue Doppler, extremely low value. So this patient already was in a more advanced level, and this patient was moribund. I show you, several levels. This is a lady who was around 50, and we saw her in the ICU, and basically, she was moribund. At that point, basically, she lasted a few days. It was too late. Diagnosis took too long. She had been complaining of symptoms, had had a coronary angio done by somebody else, and all kinds of things. But nobody had made a diagnosis until she showed up hypotensive and basically dying. That's more of her echo. So you can see that the EF can be, but the thing is the cavity is always okay, normal. You don't dilate, they don't dilate. They always have dimensions that are relatively small with variations in the ejection fraction. Now, this is something more recent that have come up, is that if you look at, even in the 2D echo, just looking at them, you frequently see a little better wall motion in the apical regions than the base, and when you do speckle tracking, that shows up as the so-called apical sparing. Nice, you see it, you can write in your report, you can have one more evidence to say, so yes, amyloid, but don't hang your hat on that one. Particularly, it's not specific. I can show you hypertensives, I can show you aortic stenosis that have the same finding. So it's not, a slam dunk, but it's nice, you see it. It's one more thing that you have to write in your report and suggest the possibility of amyloid. So nowadays, of course, when you suspect it, there are many other things that you can do. Here, because of our expertise, we frequently go to a CMR, and we're going to hear soon about that. But of course, you have also pyrophosphate scanning that can be used, and I'm sure that we'll hear next year more about PET. So, and then you have blood work. There are now labs that we can do. So nowadays, we are a lot better prepared to diagnose amyloid than we were 10, 15 years ago. And of course, the importance is that the early detection is very important because treatment is now available. But frequently, the suspicion starts in the echo lab. That case I showed you, the lady who was dying, basically, she saw previous cardiologists. They just missed the boat. They went through coronary disease, stress testing, coronary angiograms. And by the time it showed up, it was too late. So this heart is not dilated. The F is a little down. Okay. What is it? PA pressures are high. So we have a little bit of a reduction in EF. We have a funny looking diastology pattern with a fast heart rate, a uni wave. And importantly, if you look at this, is this an E wave? Well, look at this. It's a P. So we have a prolonged PR interval with a P wave, and this is truly a summation EA. That throws diastology out. We cannot do any diastology assessment. However, the PA pressures are high. So, slight reduction in EF, high PA pressures, long PR interval. What should that make us think? Anyone? Sarcoid, correct. So again, there's nothing here that comes out saying sarcoid, sarcoid. Now, if you know the patient also has pulmonary sarcoid, then you're in great shape, okay? So that's exactly the situation that we have in our business, is that there are actually criteria that have been put together, and usually starts by having a patient that already we know they have sarcoid. That makes life easier. And then if they show by EKG some of these findings that you see here, right bundle branch block, axis deviation, AV blocks of different kind, VTAC, PVCs, a lot of ST changes, you see any one of those things together with the history, you are more into it. And then you can look for perfusion defects, hemodynamics. Today, what do? We order a CMR, and we'll hear more about that. Okay, what about this one? What about this one? This guy is very sick. Look at the tricuspid valve. Whoa, what happened there? I hope this is the only slide where that happened. Otherwise, you guys have all been very, very respectful. Yeah. Thank you, sir. Okay, do we need a Doppler here to know how severe the TR is? No, look at that. They're waving at each other, bye-bye. No need for any Doppler. Which is worse, the RV or the LV? Flip a coin. Yeah, very bad, right? This could be many things. This could be many things. Turns out to be a very severe case of One more, well, look at the Doppler. We cannot even see a color Doppler in it. And there's just laminar flow through the tricuspid valve. So what's the diagnosis? Is again a bad diagnosis because it was too late. Too late. By then, there's very little you can do, okay? You like to pick them up a little bit earlier than that. All right. So there's no distinct features, and I think that as a general rule, any new heart failure patient that we get, serum ferritin is a very simple test. I think it should be in the check mark of any new dilated cardiomyopathy heart failure. It's simple enough, you never want to miss it. All right, this is one of the very few we have. I don't know how many we have, but this is probably, I'm glad we found this one, but what's the diagnosis? It looks like apical hypertrophy, right? Except look at the texture of this area here. It just kind of looks different from the rest of the myocardium, right? So that's the tip-off. Yes, yes, look at that thing there. And even here, it looks different, okay? Now, if I also tell you that the eosinophil count is very, very high, then you would have a diagnosis, right? And myocardial fibroblastosis, Leffler's. This one actually does have a relatively typical echo feature that should allow us to suspect it. And we've had a few times that we have in the echo report say, get a CBC or something, because, they always have a very high eosinophilics. And this is taken from Susan Wigger. She was kind enough to give me a classic. Again, at times it looked like a clot, like a thrombus in the apex. There is the infectious type, which I don't think I've ever seen, even though in Puerto Rico we did have schistosomiasis, but I was too dumb then to have picked it up. And then there's the non-tropical, the one that we more likely see, which is the one that has the high eosinophils. And the whole idea of that these are abnormal cells that are very toxic to the endocardium. There's some medical treatments now. Also, there have been a surgical treatment. There have been surgeons that come in and scoop that stuff out of the apex and claim patients have gotten better. And if we see a case, we're going to show it in 20,000 conferences and have all kinds of discussions because it is a rare disease, okay? A couple of last things, Takotsubo, I'm not going to spend too much time because we do see this quite often. I think everybody here is tuning to it. I come in as the reading attending and already the fellow had put in suspect Takotsubo. So you guys do a good job of that. Basically, you have an acute setting, what looks like an acute MI, frequently associated with a very stressful event on that patient's life. Regional one motion abnormalities, which can be apical, looking like an LAD. In this case, this one looks like an LAD infarct, but they can also be non-ischemic. They don't follow a pattern. For example, mid-wall. You may have the whole mid-wall ekinetic, and the apex and base are okay. Doesn't follow any coronary territory. However, the very first cases that were shown were apical ballooning. They actually did look like an LAD infarct, but you shoot the coronaries, and they're normal, and frequently, with medical treatment, they do well. And it's very interesting that nowadays, you should all know, this is another one. Yeah, this is another example. This is moving a little slower, but okay. And this one has this mid-wall that we talk about right there, and then full recovery. That there is a model. Actually, you can induce it now. So they have developed a model that they can take the rats, expose them to physical stress, and then they develop the syndrome, and then they can be prevented by pretreatment with alpha blockers or beta blockers. So it's very interesting that now the current theory is that this is a catecholamine toxicity, a catecholamine induced by just a rush of catecholamines associated with the stressful event. Overall, they have a relatively good outlook. However, there are cases that remain with LV dysfunction and continue to have issues. But I would say, 75, 80% of the patients do follow a course, and a week, 10 days later, they have recovered function, and they do okay. I'm not going to talk much about this. Dipan will cover it a lot better. I think this is probably one of the most difficult ones to diagnose. When they're obvious, yeah. When you have a young person that has an RV that goes like that, and a lot of arrhythmias, yeah, that's easy. But more subtle cases can be more difficult. They have talked about apical aneurysms or apical akinesis, enlargement of the RV dysfunction, and therefore, as always happens, whenever you don't have perfect diagnosis of anything, people create this criteria. So an enlargement of the RV, some element of dysfunction, either diffuse or localized, and then you exclude other causes of that. LV usually normal, although there have been some rare cases, and nowadays, again, more and more, we are depending on MRI. And I leave you with this last slide, which I'm sure Dipan might show it too, because it's an introduction to him. And don't complain. Half an hour left, you? Okay. They did better than Dr. Naga the other day. Okay. And the reason is that a lot of these entities that you have here are now treatable. And the earlier we can diagnose some of these entities, the more we can intervene and do something to alter the course. And that's why I think this is important. Otherwise, it would be an academic exercise. But certainly with hemochromatosis, with sarcoid, with amyloid, the earlier we picked any of these, the sooner we do have some treatment. So segue for Dipan, so he can tell us about CMR. Now, don't repeat the same slides, and don't come back with the same slide with the echoes, okay? We've done that already. Go straight to the business. All right. All right. Yeah, you can connect.
All right.
Let me just, let me do one thing. Let me come out of here so that you
Tyree?
can have me. Here we go.
Okay, now this is going to be a hard act to follow here. Dr. Q is in prime form today. So I'm going to get right to it. And Tyree, can you... Let's see. Can you guys project from the laptop?
There you go. Got it plugged in. Give it a second. Just got to change it over here.
Okay.
Go VGA. And you're hot. There you go.
All right, let me get over here. Okay, so obviously, I think when we talk about heart failure and cardiomyopathy, I think the first thing that you want to know is what's the ejection fraction. And so I think there is a role for CMR when it comes to ejection fraction assessment as well. And obviously, I think that the reason is because, we know that people with depressed LV function, the treatment options and the prognosis may be different than people who have heart failure with preserved ejection fraction. I'm not even going to talk about the echo images here. I'm just going to keep going right past them. But in cases when, the echo is suboptimal, it's the guidelines say that's a case where you should move on to CMR, both for assessment of volumes as well as assessment of ejection fraction. Now, the other important thing I think in a patient that presents with new onset heart failure or cardiomyopathy is really identifying whether this LV dysfunction is due to coronary disease or it's in the absence of coronary disease. And again, the important reason for that is because we know that if patients have disease that's due to obstructive coronary disease, you're going to manage them differently. So it has really management implications, but also prognostic implications. This is some data from Mike Felker also showing, in fact, that if you just look at all comers with ischemic cardiomyopathy, their prognosis is worse than all comers with non-ischemic cardiomyopathy. So really, there's two important things there. Now, the next thing you want to look at is, in ischemic cardiomyopathy, we talk about viability imaging, and it's really to try to identify the presence or absence of viability and likelihood of improvement in contractile function. But we already talked about that a few weeks ago. And what I want to try to touch on now is the fact that there's a new angle to viability that CMR can introduce. And it's because of this ability to directly visualize myocardial infarction or scar. And I'll show you how it's going to actually be very helpful in a variety of non-ischemic conditions as well. But let's wrap up here with ischemic cardiomyopathy. One of the things we know is that in general with ischemic cardiomyopathy, you're going to have injury that's going to be subendocardial based. So either it may be just subendocardial, as we see in the image on the top, or it may be full transmural, as we see in the image on the bottom. But in both cases, it starts with the subendocardium and works outward. Now, so when you have a patient that presents with new onset cardiomyopathy, is there a role for just looking at wall motion abnormalities, and can that help you in identifying if this is ischemic or non-ischemic? I'll show you two cases here. These are two patients that presented with new onset heart failure. And just looking at wall motion alone, I think we'd have a hard time being able to tell which is the one that's ischemic and which is the one that's non-ischemic. In this case, they both have somewhat global dysfunction. But if I show you now the delayed enhancement MRI, and I posit the same question to the audience, how many of you think the patient on the left is ischemic? Raise your hand. How many of you think that patient on the left is non-ischemic? Raise your hand. See, only Dr. Q. So the reality is that just simply looking at the presence of myocardial injury can in fact help you. And by cath, the patient on the left had diffuse disease. Patient on the right had non-obstructive CAD. Right, so I'm gonna show you some data to address that question because I knew that was coming. So here's another example. This is more regional dysfunction. And again, by wall motion, you can't tell. But if you look at the delayed enhancement, the patient on the right has evidence of ischemic pattern myocardial injury. In this case, it's transmural in nature in the anteroseptum corresponding to LED. And in fact, by cath, the patient on the right hasn't included LED. So now, there's been several studies that have looked at this. And what they've really found is that if you have significant LV dysfunction that's due to coronary disease, there's almost always going to be some evidence of hyperenhancement. So to answer your question, yeah, very acute onset cardiomyopathy, is it possible? Maybe, but I think the data suggests, in fact, that's 98 to 100% likely to pick it up just simply based on the presence or absence of LGE. Now, obviously, beyond identifying ischemic or non-ischemic, we know that in the ischemic setting, the amount of hyperenhancement predicts the likelihood of improvement in contractile function, both on a segmental basis as well as on a global basis for per patient standpoint. Now, let's turn now to all these other cardiomyopathies that are not due to coronary disease. And so if you remember, the one thing I mentioned is this wavefront phenomenon that typically is the hallmark of ischemic injury, which is that it's got to start in the subendocardium and extend outward over time. So what happens if you have a patient that has an area of myocardial injury that only affects the epicardium, as is shown on the left-hand side here, or that affects the mid-myocardium on the very left here, or the very right, where you have this diffuse global pattern of hyperenhancement. So none of these are patterns that would fit with what you would expect from ischemic injury. So when we see this, we would say, yes, there's evidence of myocyte damage here, but it looks like it's due to a non-ischemic origin. Now, what I'm going to do here in the next 20 minutes is walk you through some of these different cardiomyopathies. And as has already been shown, all non-ischemics are not created equal. In fact, depending upon what the underlying cause of the non-ischemic is, the prognosis can be, in fact, very, very different. So this is just a list of the different forms of non-ischemic cardiomyopathy that CMR could be helpful with. And let's just go through these one by one. So let's start with ARVC, arrhythmogenic RV cardiomyopathy. So the key thing for this, I think, is keep in mind is that there's major and minor criteria for the presence of RV dysplasia. But notice, both your major and minor criteria require one thing to be present to begin with, which is regional RV akinesis, dyskinesis, or dysynchronous contraction. So the point is, if you have normal RV wall motion, then that's it. You don't need anything else. You can't have RV dysplasia with normal RV wall motion. Once you have wall motion abnormality, then you look at quantitative criteria. So for major criteria, it would be basically a RV end diastolic volume index of greater than 110 for men or greater than 100 for women, or an RV ejection fraction of less than 40%. So again, starts with wall motion abnormality, and then you have to have some quantitative marker of either dysfunction or dilatation of the right ventricle. And then a minor criteria would be basically when the RV end diastolic is between 100 to 110 for men and between 90 to 100 for women, or the RV ejection fraction is between 40 to 45. So on this example right-hand side here, I'm showing you an example of a patient who, when we look at their CMR, you can see there clearly is wall motion abnormality in this patient in the subtricuspid region in the right ventricle. And by quantitative measures, we actually identify both LV dilatation with an end diastolic volume index of 136, as well as RV dysfunction with the EF of 39. So therefore, this would fulfill a major criteria for ARVC. Now, here's another example. Yeah.
But you need to have more than that.
What? So
You need to have, no, it's from the clinical point of view. For
So
example,
this is-
pulmonary hypertension potentially could make something look similar.
Right. So again, this is in the absence of another cause, and then this is just one criteria. Now, to make the diagnosis, it's a list of criteria that you need. So you need two major criteria, or you need major and minor criteria, which includes clinical, family history, EKG, everything else. And so I think an important point there is that imaging alone is not going to make the diagnosis, but at least it can get you halfway there by providing you with one major criteria. Okay, so let's keep going. Here's an example here. And what's the diagnosis here? So obviously, I think it's fairly straightforward. You've got normal wall motion, but you've got hypertrophy in the apical segments. So this is an example of apical hypertrophic cardiomyopathy. And in addition to being able to identify thickness of the wall, in fact, oftentimes some of these patients with apical HOCM will actually have an apical infarct, and that's actually thought to be due to essentially apical trapping from obstruction by the hypertrophy that leads to a massive increase in pressure at the very apical cap. Now, what about the more garden variety asymmetric HOCM? So obviously, our CMR is going to be useful to identify hypertrophied segments, to look at the ejection fraction. In other talks, we'll talk about how we can use it to try to quantify the severity of the mitral regurgitation. But I think the other area where it's useful is when we give gadolinium contrast, and you notice there's hyperenhancement present in patients with hypertrophic cardiomyopathy. And again, what's the pattern though? This is not what you would see with coronary artery disease. It affects the anterior and RV insertion sites of the septum. And it generally tends to be in the middle of the myocardium. Sometimes it may extend subendocardial as well as epicardial regions as well. And that's not the only area. It can affect any segment, but that's the area that has the greatest predilection in hypertrophic cardiomyopathy. So you see a thick wall and you see this, and that makes a diagnosis of hypertrophic cardiomyopathy very likely. Not only does it help you with diagnostic purposes, it can actually help you with prognosis. And this was a very nice multi-center observational study where they looked at patients with hypertrophic cardiomyopathy and quantified the extent of late gadolinium enhancement and found that with increasing amounts of LGE, the prognosis in these patients is worse. And in fact, this not only predicted both overall survival as well as sudden cardiac death, but it also predicted those patients who are more likely to go on to have end-stage HOCM death. So I think it really is a powerful tool, both from diagnosis as well as prognosis in HOCM patients. Let me skip this.
Dipan, has this made prime time now? Because I think the guidelines still do not use
the U.S.
these.
guidelines, I don't think, because the HOCM guidelines were last updated in 2011. The European guidelines do have it as one of the things that kind of help put you over, if you're on the borderline.
For an ICD?
To switch you over, right, yeah. So, but the U.S. guidelines, they're probably due for a HOCM guideline update at some point as well. Here's another condition, and this is Takotsubo's cardiomyopathy, which we've talked about already. So obviously, we have a number of criteria that you need to make this diagnosis, and we know that this is transient regional wall motion abnormality that occurs beyond a typical coronary artery distribution. It has to be obviously in the absence of angiographic evidence of coronary disease, and typically you're going to want to, you'll see new EKG changes of some kind, and then they should not have other conditions that could mimic this. I think where CMR is helpful not only in identifying the classic wall motion abnormality, but in fact has helped us in identifying differing forms of Takotsubo. So the most common form, which in this multi-center study published in JAMA, was the apical ballooning pattern, which they saw in about 82% of their patients. But then you also have some patients who have more of a mid-wall ballooning pattern, as is shown here, and that was present about 1 in 5. And then a very small percentage, 1%, actually had what they refer to as a basal or inverted ballooning syndrome, where in fact the apex is spared, but it's the basal segments that are affected. And about 1 in 3 had biventricular abnormality, where they had both the LV that showed ballooning as well as the RV that shows this abnormality. In addition, when you do your delayed enhancement imaging, you find really that there's no evidence of hyperenhancement, certainly when you're using a 5 standard deviation threshold. So it's suggesting, in fact, that there's not a significant burden of myocyte damage that occurs. And that's also consistent with the troponins that you typically see, which are on the order of very minor elevations. And then, as expected, most of these patients, when they brought them back for follow-up imaging, actually showed normalization of their LV ejection fraction, as is shown on the left-hand side, as well as reduction in the LV volumes, as is shown on the right-hand side of this graph. So let's move on to another case, and this is a 44-year-old gentleman who comes in with new onset chest pain, has a history of tobacco abuse, and a family history for premature coronary disease. His initial presenting EKG shows just some nonspecific ST segment changes, but no clear ST elevation. He gets put in on a Friday afternoon with IV heparin and 2B3A inhibitors. When he gets over the weekend, has a peak CK of 1,050, MB of 105, and a troponin of 30. So truly a significant enzyme elevation. But then on Monday morning, your interventionalist takes him to the cath lab and says, looks like the coronaries look pretty good. So the question then Monday afternoon is, you're making rounds, what's going on with this patient? So obviously, there's now increasing awareness of this condition called MNOCA, myocardial infarction with non-obstructive coronary disease. There's a variety of different things that can be in the differential here. This is a case, I think, where CMR can be very helpful. This patient gets brought down to the CMR lab Monday afternoon, and what do you see? So and again, remember, if there's myocardial infarct, the pattern is going to be subendocardial based. If it's a non-coronary pattern of injury, then you have to think about something else. So what do you see here? Maybe the arrows might help. Make it easy. You got multiple little patchy foci of enhancement in the lateral wall. This is classically what you would expect to see with myocarditis. And in fact, there's a very nice German study that came out a few years ago where they looked at a series of patients that presented with clinically suspected myocarditis, and they were able to do biopsies within the left ventricle at the site where they found hyperenhancement by CMR. One example case is shown here where you see a epicardial pattern of enhancement here in the infralateral wall. And what they found by biopsy was that in the vast majority of these patients, if they biopsied at the site where there was hyperenhancement, over 90% of the time, they actually found evidence of active virus. Most of the time, parvovirus, and occasionally the herpes type 6 virus. What they also went on to demonstrate is that the different viruses tend to have a predilection for different regions. So the parvovirus, which is shown in the very top panel, tends to preferentially affect the lateral wall, whereas the herpes type 6 virus tends to have more of an effect on the septum, causing kind of that mid-wall septal scar pattern that we see. And then, most importantly, I think, again, not just from a diagnostic standpoint, from prognosis, when they looked at, this is a follow-up study with a large series of patients that presented with clinically suspected myocarditis, simply the presence or absence of having any lake element enhancement had a pretty significant discrimination from prognosis in these patients, both from the standpoint of all-cause death, cardiac death, as well as subsequent sudden cardiac death. Now, here's another case. What's the diagnosis? One of the fellows? So what do we see here? So we see pericardial fusion. There's some increased wall thickness. It's about 1.6. RV actually is a little hypertrophied as well. Mitral enlargement. LVEF mildly depressed. RVF mildly depressed. And increased LV mass. So I think all of us may say, oh, I think I've got an idea what it is. I think I know what it is. But let me show you this. What do you think now? This is easy. It's not a trick question here. Yeah, this is amyloid. Yeah, but this is the classic pattern. You see diffuse there's no myocardial infarct that could give you this, right? This is diffuse enhancement. Notice not only is it affecting the LV, but look at the RV as well, right? If my pointer, I can't find where the pointer is, but if you look at the RV, look at the atria on the 4-chamber view at the bottom. You see hyperenhancement there also. The papillary muscles also show hyperenhancement. This is classic pattern that you see with amyloid heart disease. Now, again, not only from a diagnostic standpoint, prognostically, if you have patients with known extracardiac amyloidosis, typically by fat pad biopsy, when you do a CMR on them, if they have evidence of LGE, the prognosis is quite impaired versus the absence of LGE. And in fact, in this study, this is single center, they actually showed that presence or absence of LGE was better discriminator of prognosis on the left-hand side than looking at something like New York Heart Association class, where even patients that are class 1 with extracardiac amyloid tended to have a worse prognosis. And then this is now just another study that we did more recently in a multi-center fashion, again, demonstrating the same findings, which is that extracardiac amyloid, if you have the absence of lake element enhancement, your prognosis is much better than if you have presence of LGE, which indicates really cardiac involvement. Here's another case, 40-year-old presents with 2 episodes of syncope at home and also notices increasing shortness of breath for the past month. Any EKG readers out here? Who's a first-year fellow? You guys must be, tell me what this EKG shows. Isaac, why are you sitting in the way back? Come on up, buddy. Okay, Rusha went right to it. So yeah, this person's got heart block, right? There's a high-grade AV block here, and Rusha goes straight to the diagnosis of sarcoid based on the EKG. So you ready to put a pacemaker in this lady? Okay, so this is the echo that was done on this person, and is it playing? So it looks like normal LV function, maybe a little bit of area of thickening in the septum, but overall not super impressive. When I show you the CMR, you'll notice, yeah, there is definitely hypertrophy in the septum, but notice also there's actually some hypertrophy here, a localized area in the RV subtricuspid region, and then also, I'm not sure if you can see it that well, in the lateral wall at the mid to apical area, there's also a little bit of area of increased wall thickness. When we do our delayed enhancement MRI, what do you notice? Those 3 areas all show evidence of hyperenhancement, both in the septum, in the right ventricle over here, as well as in the apical lateral wall. And you couple this finding with the T2 or water imaging, which shows basically in those same areas you have increased T2 signal, suggesting in fact that there's some acute process going on here. So that LGE that we're seeing is not something that's old or chronic, but rather something that's fairly recent and acute. And then one last thing we always do in every case is do a quick survey through the chest. And in this person, when you look at the perihilar area, you can see all these little gray shadows. These are all lymph nodes, enlarged lymph nodes. So there's evidence of lymphadenopathy. So obviously you put all of these things together, that gives you the diagnosis of cardiac sarcoid, where you've got increased wall thickness in the basal septum and lateral wall, RV free wall. You've got LGE in those areas. You've got increased water content based on T2 weighted imaging, and then you've got adenopathy. And this person went on to get biopsy and confirmed to have, in fact, sarcoidosis. This is a study which looked at, one, how prevalent is cardiac sarcoid when you use CMR criteria versus the traditional Japanese Ministry of Health criteria. And in this cohort of 100 patients with known extracardiac sarcoid, the prevalence of cardiac involvement was almost 25%, whereas only 10% of those are identified using the traditional Japanese Ministry of Health criteria. And then, let me skip forward here. More importantly, in that study, as well as in now several studies which have been done and summated together in this meta-analysis of 10 studies with over 700 patients, if you have extracardiac sarcoid and you have evidence of LGE within the heart, the prognosis is much worse than if you don't have evidence of extracardiac, or then you don't have evidence of LGE. Again, suggesting that this is able to identify myocardial damage secondary to sarcoidosis. Yep.
By any chance, do you remember in that article the events? What were the majority of events? Were they mostly arrhythmic events?
So I took those out in the interest of time. They had 2 graphs. One was looking at Brady or tachyarrhythmias, showing a separation of the curve. The other was looking at all-cause mortality. And
right, but all-cause mortality was a lot lower.
Yeah, and that study showed a separation of the curves, but again, the numbers are small. Yeah.
So a lot of the events were more one of the arrhythmic types.
Right, yeah, exactly. Yeah. Most common was tachy or bradyarrhythmic events. Yeah, Man?
Do you think we could use T2 imaging to
Yes, you could. I mean, the challenge with the T2 imaging is unless, typically you want to do your T2 weighted imaging in an area where you see hyperenhancement, right? Problem is you have to do the T2 imaging before you do the hyperenhancement imaging. So the areas that you want to, so unless you do every single slice and do basically every single short axis slice with T2 imaging, you're kind of stuck with, after you know where the area of abnormality is, you can't go back and do it again unless you bring the patient down another day, right? Now, your question is, if you know already this person, for example, who's got evidence of abnormality in a specific area on your LGE, when you want to see them for follow-up 2 months later, now you know the specific areas to probe into, so you could actually do that, yes. Okay, so, and then again, for sarcoid, I think really, we tend to see this in two different pathways. I think one is on the right-hand side where you have patients who have known extracardiac sarcoid and they're coming for evaluation of cardiac involvement. But also I think sometimes you see it on the left-hand side as this patient that presented here, where it's a patient that's relatively younger, under the age of 60, who presents with unexplained advanced AV block or unexplained VT, or unexplained heart failure, that oftentimes CMR can help to identify the clues that lead to ultimately establishing the diagnosis of cardiac sarcoid. Here's another condition, Anderson-Fabry disease, where we already saw it's a condition that leads to hypertrophy, but for whatever reason, it tends to have a myocardial injury or hyperenhancement that affects the infralateral wall at the base. So that's, again, is a kind of a classic pattern that you would see with Anderson-Fabry. Non-compaction, obviously, we use just simply cine MRI to look at the morphology of the left ventricle and the trabeculations. And then there's a set of criteria that were proposed by Peterson about 12, 13 years ago, where they suggested that a end-diastolic ratio of non-compacted to compacted myocardium of more than 2.3 can be useful in discriminating between non-compaction versus other conditions that can also lead to hypertrabeculation. And then let me touch on cardio-oncology, and this is one area I think that's an emerging application where CMR could be useful. And again, it's where you want kind of serial assessments of ejection fraction over time. Now, obviously, just from a practical standpoint, you can't do CMR in every single cardio-oncology patient because there's not enough scanners that are out there. But I think one of the advantages of CMR may be the lower reproducibility or the tighter reproducibility in measurements. With echo, it's about 9 to 10%. With CMR, most studies suggest about a 3 to 5% difference. But I think beyond that, this is some work from Greg Hundley and his group out at Wake Forest, where they actually looked at something else, which is that we know that changes in EF can sometimes also be load dependent as well. And so you've got this patient on the left-hand side here who has basically a reduction in their LV end diastolic volume as well. And they propose that this may represent more of a volume depletion state, whereas a true reduction in ejection fraction is when you have not just a decrease in calculated ejection fraction, but also an increase in LV end systolic volume. So again, this I think is more an emerging application. There's also other work that's being done in cardio-oncology to look at myocardial fibrosis imaging techniques to see if we can identify early patients who are developing cardiotoxicity. But again, I think that's more investigational at this point. And then lastly, let's touch on these garden variety, what we call idiopathic dilated cardiomyopathy. And is there a role for CMR in these patients? Well, one of the things we found is that some of these patients with dilated cardiomyopathy, in fact, do have this evidence of hyperenhancement, which tends to affect the middle of the septum. So it's this kind of what we call a mid-wall stripe. And in this very elegant publication out of the UK, they were able to demonstrate that if in patients with non-ischemic dilated cardiomyopathy, having this mid-wall stripe, having this non-ischemic injury was associated with a worse outcome, both from the standpoint of all-cause mortality, cardiac mortality or need for transplantation, and then also in addition to that, from a sudden cardiac death standpoint. So, and then this is just meta-analyses looking at multiple studies that have confirmed the same findings in non-ischemic cardiomyopathy. And then last but not least, I think, is this iron overload cardiomyopathy. And so there's a CMR technique called T2 star imaging, which allows to actually quantify the amount of iron load within the myocardium. And this technique was developed in the late 90s in the UK, And I think this is a very impressive graph here, which just shows basically the incidence of cardiac death in thalassemia patients due to iron overload. And in fact, after the advent of this technique, the next 5 years afterward, there was a significant reduction in the incidence of death due to iron overload in these patients. As in the UK, they implemented kind of a systematic approach that all these patients went to a centralized, few centers that were able to do this technique. So again, I think it really, speaks to the fact that by being able to look directly at the myocardium, we're able to identify myocardial injury that occurs and the pattern of injury that occurs that can help not only distinguish ischemic from non-ischemic, but actually may help to further cone down the diagnosis or differential diagnosis amongst a variety of different non-ischemic etiologies. And so let me leave you with this final thought, which is that CMR, its role, I think, is in accurate assessment of ejection fraction to identify HFpEF versus HFrEF, can help in discriminating ischemic from non-ischemic, and then I think most importantly, it's the fibrosis that we can detect by CMR that aids both in diagnosis as well as prognosis in these patients. Thank you for your attention. And then why don't we take a couple questions? Dr. Q, you want to come up? Steve. Yeah, so peripartum cardiomyopathy, there's generally there's not a lot of data on it, but most of the studies suggest that you don't see any evidence of hyperenhancement in these patients. And that probably fits with the fact that they tend to have a fairly better prognosis.
I would imagine that the few studies that may have been done in alcoholic cardiomyopathy may be somewhat similar, that
Right.
they tend to, as a group, have less scarring because they also tend to have a better prognosis when over time, yeah. So,
Any other questions?
Maybe a thought from our pet
Yes.
colleague,
Was?
regarding, I know it's
yeah, the mic is right, yeah.
Yes.
Some thoughts, not a lecture. We'll give you more time next year.
particularly for sarcoid or whatever.
Yeah, I think sarcoid and amyloid probably are the two.
I think sarcoid will have more established role for PET in applications. I think we scanned many patients with sarcoid by MRI and PET, and there are some patients who are positive by MRI, which indicates that they had cardiac involvement. But most often, if you're not doing the T2-weighted edema imaging, which is, as all of us who do MRI know, that it's difficult sometimes to do or interpret, it may not give you information about disease activity. So if you're looking at disease activity, and even in early cases, then FDG PET might help in these patients. And many of these patients will have ICDs eventually, and sometimes not every center is scanning patients with devices. So if you want to follow disease activity after you go ahead and implant a device, this is where PET has a lot of application there. There are still a good proportion of patients where you have discordance between PET finding and MRI finding, and that could be related to the how long has these patients had involvement with cardiac sarcoid, or how the severity of the disease. There have been some racial differences among these patients. There are different MRI can detect also some other areas where it may not be active at that time, but it has had cardiac involvement in the past. So there are still a lot to learn on this. I mean, the largest series in cardiac sarcoid as of now is like 100, less than 200 patients. So there is a big room for studying this fact more and trying to prospectively study these patients and learn an outcome. And both of them can provide prognostic information. It has been published on using both modalities. For amyloid, I think this is where it's still more research. We know that myocardial blood flow is severely reduced in amyloid. So it's not only a muscle disease, it's also a microvascular disease. So these patients do not vasodilate with adenosine or regadenoson. We also know that there have been now new tracers. I mean, most of the PYP is done by SPECT imaging, by the gamma camera, not with PET. But there are some specific molecules using PET imaging that go and bind to the amyloid molecule. That's like florbitapir, and some people are using sodium fluoride. So this is where it is still early to learn. And these are used in amyloid affecting like CNS and other organs. So this is an area where there's a lot of research going on right now. I mean, not a lot, but a lot of interest, but a lot of opportunity there to go and study it further in amyloid. The role of PET in amyloid is not as much as established. An easier test would be the PYP, but the PYP also imaging by SPECT has this limitation. I mean, it's widely available, it's helpful, but it only tell you if it's AL versus ATTR, and it does not, you draw it by the absence of uptake by PYP. So, but it's a good point to start with and then take it to the next level with PET.
All right, thank you, everybody.